All right, so what is celiac disease? That's the name of the lecture today. So celiac disease, I will put a text first before we jump to the pictures. So on your right side here on the top, you see this is the small bowel. Celiac disease involves only one part of the GI tract, and that is small bowel. On the left side, this is the normal gut. As you could see, nice villi. Those are this kind of finger-like structures in the small bowel, and this is what makes us get our nutrients from food into our bloodstream. This is how we feed ourselves. On the right side, you see how the small bowel looks in the celiac patient. As you can tell, it's swollen, has no villi, it's thick, and you could not get any absorption of any nutrients when you have celiac disease with this kind of a small bowel. And the reason is that this disease, celiac disease, what it does is makes your bowel very inflamed, and it's all related to the gluten. So by definition, celiac disease is an inflammatory state of the small intestine that occurs in genetically predisposed individuals. So not everybody can get this, which resolves with the exclusion of gluten out of your diet. Can you hear me okay? No? Okay. There is a prompt clinical histological improvement following a strict adherence to a gluten-free diet. Okay, so that's rule number 2. You should be getting better when you're on a gluten-free diet. And there should be a clinical and histological relapse if you get gluten back into your system. There is different types of wheat intolerances. One of them is celiac disease, but the others are not. So an allergic response to gluten or non-gluten proteins like Baker's asthma or dermatitis or wheat-dependent exercise-induced anaphylaxis is one group of reactions to wheat. T-cell mediated response to wheat is celiac disease. Then we also have something called epithelial or innate immunity to wheat proteins called non-celiac gluten sensitivity, and I'll go over each one in a second. And the last one is luminal intestinal distension via fructans, and that is something what we call IBS. That is a lot of symptoms similar to celiac disease, but the patients actually do not have inflammation of the small bowel created by wheat. So the first group of diseases is related to something called IgE-mediated reaction. So this is like a peanut allergy type of reaction. So you get short of breath, you swell up, your throat swells, and so on. This is what it does. But that's not celiac disease. Celiac disease itself is a slowly developing immune response to wheat, where, again, your small bowel gets inflamed and you have a lot of GI symptoms. But you do not need an EpiPen to treat this. Epithelial innate immunity to wheat proteins, so this is called non-celiac gluten sensitivity, is where patients report that somehow they feel really sensitive to wheat, like bloating and diarrhea. But if you do blood tests and endoscopy, then the tests are negative. But they will tell you they feel really, really bad when they ingest gluten. So we call them sensitive to gluten. Some of them can follow a gluten-free diet. Some of them can do partial gluten-free diet or not strict gluten-free diet, whatever they can tolerate. And the last group is the IBS symptoms, where sometimes patients with IBS report that they do really well on a gluten-free diet. And we do not know if that's related to wheat or gluten, or it's related to other substances that's contained in wheat, one of them being fructans. This is a microscopic picture of the, again, small bowel, which is normal. You can see this finger-like villi, and this is how it's supposed to be when you're doing endoscopy. And on the right side, we call it, this is how looks the atrophic mucosa of the small bowel. And you can tell when you're doing endoscopy on a patient like that. So what you need to do is to get a biopsy to prove that. So a little bit of history. So this was first recognized as a clinical entity in the 1st century AD. Sprue, the term sprue, which is also given to celiac, is derived from a Dutch word sprue, meaning aphthous disease, and that was described in the 18th century. In 1888, Samuel Gi published a book called On the Celiac Affection, where he concluded that the treatment was through specific diet. And then in the mid-20th century, Dr. Dick becomes convinced that the wheat is what the cause was of the poor health in his patients. There was also an observation during the Second World War where there was a shortage of bread for soldiers, and they noted that some of them were actually doing better if there was no bread for them to eat. And they thought that those particular soldiers had actually celiac disease. And of course, most of the soldiers in the Second World War were Europeans, right? So that's where celiac disease was predominant. A little bit of epidemiology. So in general, in world, the rate or the incidence of celiac disease is 1%. For example, in Finland, they're saying that it could be 2.4%, so it's a little higher. The higher you go on Earth, the higher is it longitude or latitude. And the northern part of Europe or southern part of world, the celiac disease becomes more predominant. Okay. United States is thought to be approximately 0.8 person per 100, so it's 0.8%. It is similarly high in Italy and parts of Austria, so mostly Europeans again. Incidence is also increased in the area populated by Europeans, for example, the United States, as I said earlier. When we talk about gluten, that is a protein that's used as a storage protein in a family called triticale. So that's the grains family. So anybody has an agricultural degrees? No? So we have a family of graminae, and then is divided in two different big groups. And at the end, when we come to subtribe or genus, we have three groups: wheat, rye, and barley. As you could see, oats is not in this group. So wheat has gliadin, rye has secalins, and barley has hordeins. So those are three types of proteins or parts of grains that actually thought to be contributing to celiac disease. Let's talk about pathophysiology. How is actually celiac disease happening in the GI tract? So gluten is often used as a generic term for disease-activating proteins from cereal grains. And those are two types, gliadin and glutenin. This gliadin, this molecule, it is the alcohol-soluble component that contains the bulk of these toxic components. Is resistant to gastric degradation, also resistant to pancreatic and intestinal brush border membrane proteases. So in other words, this molecule, like any other food, is supposed to be destroyed in the stomach, small bowel, and gets absorbed. Now gliadin doesn't do that. So it's resistant to all the enzymes that the stomach makes, the pancreas makes, and the small bowel makes. So there is a direct interaction of this molecule with your intestinal wall. So these molecules cross the epithelial barrier and then interact with some cells called antigen-presenting cells, which I will show you in this cartoon. So what you see here is, on the top part, this is the lumen. This is where the food goes, let's say, from the left to the right, from upstream, downstream. These are the cells that cover our small bowel. And this is the subepithelial layer of the intestine. This is where all the immune cells are located. So as you could see on the top of the cells, we have this microvilli, which is supposed to absorb all the nutrients. So then we have ingestion of gluten, which gets degraded in gliadin, which on itself does not get degraded. What it does is penetrates through the cells, epithelial cells, and interacts with the immune cells in the layer below the epithelial layer. So the first cells they interact with is called antigen presenting cells. That's like another name, it's called macrophage. So this is the cell actually has recognition of anything that we interact with. And one of them is gliadin, has receptors. So this molecule, gliadin, gets deamidated. It's some kind of one type of a chemical reaction. The cells sends the signal of this interaction to something called a T cell. It's a memory cell. This cells comes in, interacts with the antigen presenting cells, and recognizes as something foreign, so it doesn't like it, and then produces some molecules which call other cells called B cells. Now these B cells produce antibodies. So you have more T cells coming in, you have B cells coming in, producing a lot of antibodies, a lot of molecules. So CD4 cells or T cells, they produce cytokines. The cytokines actually interact with the epithelial or the epithelial layer of the cells and makes them swollen, inflamed, they don't like it, and that's how you get atrophy of the bowel. You see the length of the cells changes from the left to right, it becomes, the cells become sicker. They also produce antibodies, and this antibody is actually recognized by our blood tests in the lab, when we can tell that somehow these B cells don't like this molecule, and that's how we know somebody is predisposed or has celiac disease. So overexpression of molecules like interleukin-15 leads to this inflammation as well. So this is how it's actually happening every day or every minute in celiac patients. And of course, the treatment will be to eliminate this molecule. If you eliminate the molecule, there is no interaction, there is no cascade, and these cells kind of dissipate and disappear from the layers of the small bowel because the cells recuperate every 2 weeks or so. So what are the clinical signs of celiac disease? So I put them in 3 groups: childhood, adolescent, and adult. So I do not see children, but based on literature, they will present with steatorrhea, so that is fatty diarrhea, nausea, vomiting, failure to thrive, irritability, muscle wasting, hypotonia or very weak muscles, and abdominal distension. Okay, so if a mom has a child, if a mom has history of celiac disease and has children with this type of symptoms, those children need to be tested for celiac. In the adolescent presentation, you can see neurological symptoms. These kids don't grow, and they can get anemia. So then the red flag should be raised, and these children should be tested. And then adult presentation is very different. There's a lot of different symptoms, and some of them are very confusing. But in general, you should see diarrhea. That's 50% of patients will report that. Unexplained anemia. Osteoporosis, which is the decreased amount of calcium in your bones. Less common features are abdominal pain, rashes, again, low calcium levels in your blood, low levels of protein in your blood. Liver function tests are slightly elevated, especially the number called, the test called ALT. And these people come in and usually say, okay, I was diagnosed with IBS 20 years ago. But 20 years ago, we didn't have good celiac testing. And you do a celiac test and it's positive. So these patients will come in and literally tell you that they have IBS for many years. So how is celiac disease classified? So CD stands for celiac disease. So we have classic disease where there is evident GI symptoms. You have atrophy of the small bowel, so that's villous atrophy, symptoms of malabsorption, and resolution of symptoms and mucosal lesions on a gluten-free diet. And then we have the atypical celiac disease, where not everything looks like a textbook text. Patients exhibit only minor GI symptoms. They can have anemia, they can have dental enamel defects, osteoporosis again. Joint pains can occur too. Abnormal liver function test, ALT, more than AST. Women can have infertility. And patients can have neurological symptoms like seizures sometimes, which are unexplained. And these patients will have mucosal changes when you do an endoscopy again, which is needed to be proven, and they will have positive antibodies, serology. So to continue on the classification, there is also a silent celiac disease, there is a latent celiac, and there is a refractory celiac. Okay, so silent. So these patients have no clinical symptoms. It is diagnosed incidentally with a positive blood test, and these patients will have typical histological changes on the endoscopy again. But then when you put them on a gluten-free diet, they realize that they're really tired for a long time without knowing what the reason was. Latent celiac, these patients have minor symptoms. They have normal mucosa, meaning the small bowel looks okay, even if they eat gluten. But they could have had celiac disease in childhood, but recovered the gluten-free diet and continue to be asymptomatic on the regular diet later in life. So somehow the immune system of these patients has decided that it's not going to interact anymore with gluten, so they do not get any symptoms and no pathology in the small bowel for a while. But you have to keep an eye on them because it could occur that all of a sudden they could become symptomatic. And two, these patients had normal mucosa on a normal diet, but later in life, they all of a sudden developed celiac disease. So, in other words, sometimes patients are diagnosed later in life, where they were maybe partially symptomatic or completely asymptomatic, but then all of a sudden, age of 70, they developed anemia, and you check them and they have celiac disease. So. And there is two forms which are very rare of refractory celiac. That is when patients are following a very strict gluten-free diet, but they're not improving. That's why it's called refractory. So some of them call something called ulcerative gingivitis. That's a very severe inflammation of the entire small bowel. And the other form is intestinal lymphoma. That is also known as enteropathy-associated T-cell lymphoma. And this condition is quite severe, and again, it's very rare. The reason it happens is that the immune cells in this particular patient's bowel has cloned and developed this abnormal T cells. They multiply without any control, and that is by definition lymphoma. So if you compare celiac disease to an iceberg, you can have, as you could see, this is the iceberg, and there's different levels of water. Okay. So all these patients should be genetically susceptible to celiac. So you have to have this type of a gene called HLA-DQ2, DQ8. Okay, and there is a way to test for that. If you do not have this genetic makeup, there is approximately a 99.9999% chance you do not have celiac disease. Even though our lab says there is still a possibility of 1% you can have celiac disease, but if you look in literature, they says it's almost impossible to get celiac disease if you do not have these two genes. So 30 to 40% of population have this genetic makeup, but yet the incidence of celiac is only 1%, right? So there should be other factors that make you predisposed to get celiac disease. So on the top, you could see classic celiac disease. So this is, I would say, a majority of our patients. So they have the symptoms, they have the blood test, and they have the biopsy. And then we have atypical celiac disease, lower. So that is some things just don't add up, or minor symptoms, or you could have a positive blood test but negative biopsy. You can have a silent celiac disease where your disease is just very mild. You do not have a lot of symptoms, even if you ingest gluten. So we have healthy individuals on the bottom, right? So those that do not get the disease despite having the genetic makeup. And then we have latent celiac disease, where it's, again, very silent and quiet. So, we clinicians usually see the tip of the iceberg, but we have to keep in mind that some of the cases could submerge from under the water and become classic celiac disease. sometime in life. So all these patients who have silent atypical classic disease will have positive serology and positive biopsy. So clinical features again on celiac. So peak age of diagnosis is 4th to 6th decade, so 40 to 60 years of age. 20% of cases diagnosed after the age of 60, and I've seen some of them. 6% of patients of cases diagnosed during childhood. There is more predominant disease in women, so almost 3-to-1 ratio. If you have a first-degree relative, so that would be a parent or a child with celiac, then your chance of getting celiac is 10%, 1 in 10. Second-degree relatives will be like uncle, for example, it's 1 in 40. Okay, so that's much less. Other associated diseases, juvenile diabetes and other autoimmune diseases, 1 in 60. So juvenile diabetes will be type 1 diabetic patients. I always check them for celiac when I see one. Non-GI manifestations of celiac, just to cover other not as common presentations. So neuropsychiatric manifestations, this could actually precede the diagnosis of celiac. For example, somebody has a seizure, right? And nobody can find out why, epilepsy, and you should check them for celiac, because they could have that. That could be associated with vitamin deficiencies, B1, B2, B3, B6, all the Bs, and also vitamin E deficiency. Some of the patients report migraines, some of them report depression, and so this is the percentage of how frequent that is. Anxiety, suicidal tendency, carpal tunnel syndrome, or other forms of neuropathy. You may want to check for that too. And also myopathy, which is weak muscles. You can get arthritis, which is usually inflammatory, so you may need to have celiac disease checked as well. You know, not only rule out rheumatoid arthritis or other inflammatory arthritis, but also make sure you rule out celiac disease. Metabolic bone disease, so that's usually related to vitamin D deficiency. So when you have celiac disease it's poorly controlled, you get vitamin D deficiency. And you have, that results in a higher fracture risk by approximately 30%. Your splenic function is decreased as well, so your immune response is not as responsive to some infections. One of them is pneumococcal pneumonia. So all the patients who have been diagnosed with celiac disease have to be vaccinated for pneumonia. Some patients develop kidney disease, and that is a specific type of kidney disease called glomerular IgA deposition. Very uncommon. Very rarely seen idiopathic pulmonary hemosiderosis. That's kind of a deposition of iron in your lungs. Introduction of gluten-free diet, GFD, results in remission of this condition, IPH. Now, this is the rash that develops in celiac disease called Dermatitis Herpetiformis. So you get this multiple itchy papules and vesicles, like blisters, in a grouped arrangements. 85% of the patients will have also oral inflammation or oral lesions. It may take several months or even years on a gluten-free diet for these lesions to disappear after you start a gluten-free diet. So some patients come in presenting with rash first without having any other GI symptoms, any GI symptoms. Conditions that are associated with celiac disease. So one of them is, as I said, type 1 diabetes. So 2.6 to 7.8% of patients with diabetes will have a TTG antibody and mucosal biopsy positive for celiac. The age of onset and severity of diabetes are not related to celiac. So those are just different types of diseases. Just both of them are autoimmune. There is no evidence that diabetes is triggered by celiac or that celiac disease triggers diabetes. So we want to be careful when we talk about those two conditions. And there is no evidence that shows that improved diabetes and a gluten-free diet in humans In other words, you have to follow both diabetic diet and gluten-free diet to do well. You cannot make your diabetes be better if you only follow a gluten-free diet. Other things that, again, rare selective IgA deficiency. So some patients with celiac have low levels of IgA, so we have to use other types of blood tests to diagnose with celiac, and I'll go over that later. So Down syndrome, that's an interesting thing. So 20-fold increased risk of celiac comparing a general populations and patients with Down syndrome, and I have a couple in my practice too. Liver disease. So celiac patients will have an elevated AST or ALT, and this is a test that any doctor can order. 27% of patients with celiac have abnormal LFTs, and they normalize at a 90% rate in 12 months once you start a gluten-free diet.